Okay, I want to put everything at the beginning because I don't want to run out of time because I only have 222 slides and we got less than 180 minutes. So we're gonna work through this. Everyone stand up for just a minute. For those of you who have done this, just bear with me. What I'm going to do is we're going to do a little test. We're going to blow out all of our air and see how long we can hold our breath. Okay? This is called Wim Hof breathing. We're going to find out how acidic you guys are after your lunch. All right, so breathe in. Blow all the way out, and when you've run out of breath and you start breathing, sit down. Go. Hold your breath. Just feel that need for oxygen. That's 15 seconds. Lots of patients, there's one went down, a couple went down, there's another few went down. Let's see, that's 20 seconds. Just make a note how long this takes you. There's 23 seconds, 25 seconds, 27 seconds. We got 30 seconds, 31 seconds, 35 seconds. Still, there's a 37. Dr. Walden went down at 40 seconds. We got one up still, at least one, 47 seconds, and 48. Good, okay, stop that. Okay, so this is, make a note of that because we're going to do just a little brain activation right now. We're going to drive some oxygen into your brain because we're going to be, you guys just buckle your seatbelts. We're going to be, you're up for a good ride. We're going to talk about some simple things, some complex things, and there's going to be a point where you are most likely going to be a little overwhelmed. That's okay. Just recognize it and realize where that point was. Maybe make a note. If you start getting really bored or just can't focus anymore, make a note of what minute that happens at. And that's sort of a measure of your brain fatigue level. Okay, so we're going to teach you how to increase your oxygen to your brain right now. So what you're going to do, I teach people a relaxed breath. Every patient, almost every patient that I have ever seen in my life has poor breathing when they're coming in pain, and I bet yours are the same way. Over the last 10 years, I've been measuring pre and post adjustment rib expansions on 99.99% of my patients. And what I found is that people who have back pain, people who have headaches, people who have brain injuries, people who have any pain anywhere, people who have insomnia, they all have compromised rib function. And so what I want you guys to do is to have a couple tools to change that right away, right on the first visit. So what we're going to do, instead of the relaxed breathing where you breathe in for 3 and out for 6, we're just going to do sort of a Wim Hof style breath where you do in and out. We're going to do 20 breaths. Normally Wim Hof recommends you do 1 to 3 reps of 40 of these type of breaths. And then you can test this at home. We're going to test it as soon as we do these 20. We're going to redo our breath holding test, and you're going to find out if your ability to hold your breath with no air in your lungs improves. Okay, so you guys willing to play this game for a minute?
Yes.
All right. So here we go. We're going to breathe in through your nose, out through your mouth. In and out. Let's go a little harder. In and out. In and out. Keep going. Now, I'll talk to you while you keep doing this. What you'll notice is you'll start to feel a little lightheaded, and that's normal for this type of breathing. So keep going. We're going to go 20. That's about 6 or 8, maybe 10. Keep going. Do your own breath. Just nice and breathe in all the way and out all the way, because we're going to test your exhale in just a minute. Breathe in, all the way out. And in. A little faster now. Breathe in. And out. Anyone getting tingly yet? Breathe a little harder, a little faster. All the way out, all the way in. All the way out, all the way in. Let's do 5 more together. In and out. In and out. In and out. In and out. And last one, in and out. Now, hold your breath in for just a second. And then blow it all the way out. Stand up. We're going to hold our breath. Hold it. Time it. Hold your breath. And what I find is most people hold their breath much longer after one partial session. Normally, you would do this for 40 seconds or 40 breaths. and you'll get lips tingling, fingers tingling, a little lightheaded. There we go. What's that time? 21 seconds. There's 26 seconds, 28 seconds, almost 29, 30 seconds, 35 seconds, 38 seconds, 40 seconds, 42 seconds, 45, 49, 52, 'Dr. McGinn, can you hold it past a minute? You made a minute. 101. Nice job. 105. 108. 111. 115. Write that down because you're going to try it later. 120. Is that everybody? Dr. Conger still up? You guys still up back there?
Breathing through his beard.
127 and 132. Okay, good. All right. So, did you guys have an increase? Just say yes if you had more of a breath, more of an increased time. Yes. Most of you had increased time. Good. So, this is something that your patients can do right from the beginning, even if they're on bed rest. Now, I had a sort of a brain, like this. Knowing how important oxygen is for the brain, this talk that we heard yesterday morning was just like blowing my mind. I was like, I don't know. I just had to figure out where that goes. But I'll have to look at the research and see how that can apply. But did you have a question?
Yeah, do you actually have your patients stand up?
No.
I almost passed out myself.
No, I don't have them stand up. I always have them sit down.
Okay.
But I just didn't know how else to look at this room and give you your times. So I thought that would be better. Yeah, you never want your patients to stand up while they do this. It's actually best if they can lie down. Sitting up works fine too. But yeah, you're almost on the threshold of a sympathetic stress response, and you're controlling your brainstem when you do that. You're driving oxygen into your deep primitive brain. So I have a few objectives today. I want to share with you some clues to help you understand your brain a little better. And I think you'll start to see, some of it is actually review. Some of it you learn in chiropractic school, some of it you've learned since, some of it you've learned through treating patients, but I want to help you understand your brain a little better. I also want to give you some simple screening tools that you can use to screen all your trauma patients who think they had a concussion or didn't. Okay? There's several good outcome assessments. I want to focus on 3 high-yield brain areas that will give your patients relief and help them function better. It'll also give you relief and help you function better as we go through our little quiz in just a minute. I want to share some clinical pearls in treating traumatic brain injury, and I want to help improve your ability to diagnose confidently mild traumatic brain injury. Okay? My goal here is to help save some brains. Now, why is this important to you guys? Because you all have a brain, so this is all very pertinent. Okay? You have your family members. Raise your hand if you've ever had a concussion. Okay, almost like 80, 90%. Raise your hand if you've had a head injury but you don't think you had a concussion. Okay, it can happen. It happens. But raise your hand if you have a family member that's had a brain injury that's affected their life significantly. Okay, so some of this you can use on family members right now. The literature isn't very hopeful on a lot of brain injuries. It's pretty vague in lots of cases, but what they find is, about 85%, maybe 80, sometimes 70% in different studies say that, you get better in, sometimes they say 1 month, sometimes they say 3 months, but even at the far end, 6 months, and then you should be recovered. And if they're not, they don't know what to do. And so there's other alternative providers like ourselves and occupational therapists and speech pathologists and vision-trained optometrists and neuropsychologists that deal with this. And this is really something that needs to be co-managed and co-treated. So you also need to have patience patients, you can practice on them. You can also practice on your family. But all this information will apply to all of them. And then, we're licensed as primary care providers in the state of Utah, chiropractic physicians. And so, most of us are somewhat interested in it, but let's go a little deeper today. And then I just want to share with you, I've co-treated with all those providers, including social workers, other chiropractors, medical doctors, optometrists, and it's just a great, when you see how deep this can go, you're going to realize that it's good to have other people on your team, not just as a referral source to help, feed people to your clinic, but you want to be able to manage certain parts of it that you just aren't interested in. And would you guys agree with me that there's parts of healthcare that you're just not interested in? Yes? Just shake your head. This means yes. If you're not interested, say no. Okay, good. All right. So I've had several chances to speak, and I would encourage you guys to take some of the slides that I've created and use them and share them with your patients. I have a little model in my office where I have a folder called Patient Education, and Dr. Walden and I use that every day with educating our patients because there's so many different things. You can't have a chart and a model for everything you need to explain. So take some of these slides that you really like and screenshot them and put them in your Patient Education folder and teach your patients. But also put together your own speaking plan and put together some part of this that you're interested in and teach your patients. Because if you really want to know how to learn and increase your brain function, increase connectivity, you need to teach this. So don't expect that I can teach you because you need to teach someone in order for you to learn. And that's really what I've done. Through all these different talks, I probably spent, in just the last month, I probably spent over 200 hours just on this talk right here. And so you have a chance to go through the literature, and you have a chance to sort of sift through it and read it and make sense of it all. And then you got to decide. I'm going to ask you guys to make your own decisions about how you decide to define concussion or TBI in just a moment. And then I recommend you do in-office workshops. I had a goal. I attend the grand rounds at our local hospital every Thursday at 12:30. They have a lunch, and then they speak on robotics, surgery for the uterus, or they'll speak on diabetes, or they'll speak on the amazing research on statins and how great it is for you. And I go and listen to these talks, and I just soak it in. I'm just learning what the doctors are getting educated on. And I had a goal that one day I could speak at the grand rounds, and I actually did that last fall. I spoke on Whiplash, and it was pretty fun. So if you have more patient referral sources, it just makes your life easier. You can focus on doing what you really want to do, which is help and serve patients. So let me ask you to think about this for 1 second, because in order for me to build anything into your brain, there has to be some kind of emotional connection. And so just think about why you do what you do. Is it some amazing healing transformation you had when you were injured and chiropractic took you from a place where you were dysfunctional and now you could function? Or did you see a loved one suffering, a spouse or a child going through some hard times? This is a really echoey spot right there. Just think about that. And here you are on a Saturday afternoon. You're taking your time. You've been here for several dozen hours. There's other things you could be doing on a Saturday afternoon, but you're here learning about brains. And to me, that is, I just acknowledge you for that. It's amazing. One of the reasons I do what I do is I got a call at 5 in the morning back in 2008, and my brother was on the phone, and he says, "You need to come to the hospital right now. Your dad's had a stroke." And so I raced to the hospital, and I had just, go back like 2 months, maybe 3. I had been talking to my dad. I'm like, I really want to do this neurology thing. I just feel like I need to do it, but it's going to cost money, and we're doing okay in practice, but I'm going to have to go and spend time in Chicago and Florida and Atlanta and all over the country to try to do some of these seminars. And my goal was to get certified in neurology. My dad didn't even hesitate. He said, "Do it." And I said, "All right." So I started doing some studying, and I just had barely started the program. Then I get this call, and I had probably 1 concussion patient and 2 stroke patients that I had already started treating. So when I get the call that my dad's in the hospital, I was a little nervous, but I was confident in a way, a false sense of confidence. At that point, I'd just been doing it 2 months, but I had confidence. And then I said, all right, I'm going to get my dad back. A lot of people recover from strokes. You guys all know someone who's recovered from a stroke? Yeah, so I race to the hospital, go in to the emergency room, and see my dad lying on a table, intubated, head back. He had a really far forward head posture. He would have been one of the poor subjects in Dr. Harrison's study. And he was in a coma, and he had woke up about 45 minutes before, and as he went to walk, he had already had a stroke, I think, when he was asleep, and he fell and smacked his head on the end table, and then he was still lucid. He was trying to tell my mom in gibberish that I can't hold my arm up. He would lift it up and it would drop. And so they got him within just a few minutes. The ambulance was there, and they were hovering around him, giving him medications, doing this and that, and I sort of snuck over, snooped around, looked at the computer. There's a big picture of a CT on there. And there's my dad. And so I see a picture of a CT, and I'm looking at it, and I look at it, and it's just this huge stroke crossing the midline. And I was like, that's not looking good. And I looked down at the name, and it said Mr. Gold. I'm like, oh, good. I'm glad that's not my dad's. And so then a minute later, the doctor comes over and says, I want to show you and your mom what your dad's CT looks like. And he points to this CT. And I'm like, oh, I was hoping it wasn't him. But apparently, with these cases, when it's a gold ambulance, they just put in the name of the ambulance that's come bringing them in and not the actual name of the person. So they said he's not going to make it. And so I just had just a few minutes. My mom and I decided that in his best interest, we're not going to keep him on life support. It was really traumatic, but we had no doubt. He would not want to be on life support if he didn't have function. And so we took him upstairs, and they brought him upstairs and got him cleaned up, and then we had all the family there. He was still on life support, and I just had just a minute in between, and as I was whispering into his ear, I just told him I loved him, and I told him I'm still going to be working on the neurology, and I said, it's okay, don't feel bad about anything. We'll be fine without you. And then I see this little tear just course down his cheek. And I knew he had heard me, even though he wasn't really conscious. And, we had the pulse oximeter on. The family came in, and we said a prayer as a family, and then we took the life support away. And I watched that pulse oximetry go from 95 to 90, then down to 80. And about 65, 64, and then he just sort of went gray and he just slipped away. And so this is my story. This is something that motivates me. I want to save brains if possible. Now, there's nothing I could have done for my father, but it motivates me because he encouraged me, and he always saw the best in what I was doing. I had another quick experience. I won't share this one too long, but I was swimming the butterfly in the pool, and I was just had a stressful day at work and had some events happen. And as I was swimming, I would swim, and then I'd just sort of come easy back, and then I realized my heart was just racing, and so I decided to stop and try to take my pulse. I couldn't even count it. It was so fast. Maybe it was 200, 220 minus my age at the time was about 40. It should have been about 180, but it was, as I found out, it was closer to 300 actually. And so I went home and watched a movie with my wife for a few minutes, and checked my pulse. It was down to 150. I'm like, okay, but my resting pulse is about 50. Long story short, woke up at 4 the next morning after finally getting to sleep at 2 a.m. And I told my wife, hey, if you can take me to the hospital, they can reset my heart and I can be back to see patients by 8. This is a Friday morning when I still saw people. Turns out it took a little longer. Nothing worked. They had to cardiovert me several times. My heart stopped for about 8 seconds. And that's after, when my heart was actually beating in rhythm again. But it humbles you when you have health crises. And just think about, you all have some story like that. I got another one where I broke my arm and my wrist and my other wrist and my shoulder and my elbow after crashing a motorcycle. I won't go into that one too much, but there's the healing. You see that fracture? We don't see quite as many of these, but radial head right there. So I was out of practice for about 3 months, and I don't know, it's humbling. It's humbling. So let's go into a little more detail now. It's one of my other reasons. If you think, okay, just nod your head or raise your hand if you've had a fairly close relative or loved one, a son, father, mother, somebody who's had a drug addiction issue. Anyone? Probably more than 80% of us in here. That's another reason why I do what I do, because I want to help people get out of pain. I want to help people function better without using addictive substances that actually don't fix the problem at all. So there's lots of ways we can injure our central nervous system. You can do it through trauma. You can do it through acquired methods, but there's lots of ways you can injure it. We'll be mainly talking about this area right here, a little bit on hypoxia, and a little bit on systemic, but we'll mention axonal injuries as well. There was a study. I'll put this in the folder, but I couldn't find it when I was trying to load this folder up. So I'll put there's a folder on spinal concussions and what the results are and how often the people are going back to play contact sports after having a spinal concussion. It's crazy. All right. So I got a few questions for you. If you have a piece of paper, write this down. At what age do you feel like your brain was healthiest? Where were you at your peak? Best brain function. Okay, some of you are like, right now, I'm at my peak. I will tell you that I swam in the Utah State, the Masters Championship this morning before I came to the seminar because I just did one event because I wanted to do it. I swam the 1650 and last November I swam it in 28 minutes. Today I swam it in 24:45 or something. So I'm still pushing myself at age 46, almost 47. But it was a mile's a good 66 laps. It's pretty good. All right, so from your peak function, would you say your brain's declined? Just raise your hand if your brain's declined at all since your peak function. Well, it has to be, because if it was, you'd still be at your peak if you weren't, right? So how fast has it declined? Has any of you noticed a decline over the last year? Any of you? No one? No one's noticed? Sometimes it happens when you don't notice it. We got only 5 people that are willing to admit that they have some decline over the past year, but it can happen. Now, do you ever notice that your brain function fluctuates throughout the day? There's better times, like you just are on it. You can remember things. Words come to your mouth. Words come to your mouth. You can read. You can do it without getting fatigued. You can drive, whatever it is. But sometimes you notice that if you do something later in the day, like right now, it's after lunch. I already see a few people asleep, but they're probably listening to me, just with their eyes closed, just resting their eyelids, slow blinks. Now, ask yourself this question, and just write them down if you notice them, because I'll give you some forms that I want you to go over later. I want you to fill these out, and I want you to have your loved ones fill them out. And this is sort of like a baseline, because if you don't have baselines, it's really hard to tell if you're getting better or worse. So the biggest challenge we have in concussion research is you don't have baselines for a lot of these injured athletes. Just regular old housewives and workers and whatever it is. You don't have baselines. How many of you guys have a baseline on brain function right now? No, hardly anyone. So now let me ask you this. Do you ever have trouble with anxiety, insomnia, or depression? You don't have to tell me out loud. Just think about it. Do you? These are signs that the brain is not functioning right. So if your patients have signs of anxiety, insomnia, or depression, then they have some brain dysfunction. Can we change it? I don't know. It all depends what your skill set is. Question?
How about vagus nerve irregularities, such as breathing constriction or irregular heartbeats?
It's all part of it. If you have irregular heartbeats, there could be structural issues in the heart. There could be control issues in the brainstem. So it can be either. But breathing issues have to do with the brain. If you have sleep apnea, you need to address that, because sometimes patients end up seeing 17 different providers before they even have a sleep apnea test ordered. You cannot have healthy brain function if you don't have appropriate fuel. I'll show you a chart in just a minute. So let's review some neuroanatomy. How well do you know the brain? You guys have your paper, right? I'm going to give you like 10 seconds. Get your pencil out or your pen and draw the brain and the 6 major divisions of it. You get 6 points if you can draw this. 6 points. Here we go. I think your time's almost up. All right. You guys done? You guys ever played that? There's this game that you play where you only have 6 seconds to draw something like, the Declaration of Independence. And then the time's up and you have to see if your family members can guess the drawing you just made. All right, so you have them labeled. Frontal lobe, parietal lobe, temporal lobe, occipital lobe, cerebellum, and brainstem. Raise your hand if you got 6 points. All right, half of you maybe? 5 out of 6 is pretty good, as long as you don't injure the part you didn't remember. Okay, so there's a few divisions of the frontal lobe, just for example. I mean, we don't have to go into it deep, but if you look at this, division between the frontal and parietal, this is the motor cortex, and the further forward you go, the more abstract the function goes.
Broca's area.
Broca's?
Broca's.
Yeah, that's an important area for speech. So you get an extra half point if you label Broca's area. All right, so how well do you know the brainstem? Okay, this is quiz time. If you don't know this, you need to know it, because nothing else I say after this is going to really help you if you don't know this. So I don't mean to, it's just, I just focused a lot on it, so maybe I know it a little bit better than some, but it doesn't take long. It just takes a little focus. So go ahead and draw the brainstem. Quickly. It should only take like 10 seconds. You can do it from the side or the front. I don't care. Whichever view you like best. Or you could do both. Okay? And just write down how many cranial nerves there are. Or I should say how many pairs of cranial nerves there are.
From the brainstem or from the brain?
I want to know all the cranial nerves. You should all know the cranial nerves and if they come off the brainstem or not. Okay, let's review it. How'd we do? Brainstem. Thalamus actually isn't the brainstem, but you get an extra bonus point if you remembered it. This is the top part of the brainstem called the mesencephalon or midbrain. Either way, you can call it either way. Midbrain is what this chart shows. There's another part of the brainstem called the pons. It's in the middle. It's big and fat. It's the big pregnant-looking belly. And then we've got the medulla oblongata. And if you know raise your hand if you know the division of the cranial nerves and where they're located. Can you remember that? We got one. So just divide the 3 into the 12 pairs of cranial nerves. We know we have left and right optic nerve and left and right facial nerve and left and right trigeminal nerve and all that. So we're just, the cranial nerve 1 and 2 come out of, not technically out of the brainstem, but we just, for memorization's sake, we'll say that first 4 cranial nerves come out of the midbrain, next 4 come out of the pons, so we got 5, 6, 7, and 8, and then we have 9, 10, 11, 12 coming out of the medulla oblongata. You guys doing good so far? You with me? Just a little quick review. If you already know it, you're happy and you're feeling good. If you don't, you're like, well, I got to remember that. And you may have to memorize this. All right, so there's just another view of the cranial nerves. And we have sensory and motor components, and these all should be examined. If you really think you want to treat a concussion patient, you should examine the cranial nerves because it's part of the brain. So you need to examine the eyes in all cardinal fields of gaze to look at 3, 4, and 6. You need to test their ability to smell. You need to test their ability of their eyes to converge and test the ability of the eyes to move in those different directions. You also need to check the sensation on the face, and you also need to check the motor strength on the face. You need to check the ability of the tongue to move, that's 12, and then you need to check the ability to swallow and shrug their shoulders, and it's hard to check the vagus. How would you check the vagus nerve if you were going to be a really thorough primary healthcare physician and really, truly not rely on your documentation that says, I checked every cranial nerve. How are you going to do it, Sequoia?
Heart rate variability.
Okay, that's one way. Heart rate variability.
Could you, I'm just making this up. You take the pulse, do a vagal basal response, and then redo the pulse and see if there's a change.
What are you going to do the vagal? Push on the carotid body?
Yeah.
That's a good way. I like that, but I don't like to do that actually in people who have brain injuries very much. Maybe when they're feeling better, then you can do it.
Test 9 and 10 together, they work together.
Yep, so check some swallowing. So swallowing would be a good one. Just have the patient say, ah, look in their throat. And what were you saying over there?
The gag reflex?
Gag reflex, very good. Also, just listen to the gut. There's so many people. Please ask your concussion patients or pay attention to this. The blood-brain barrier is very similar in protein to the gut barrier. And so if between 2 to 6 hours after a brain injury, the gut barrier is actually starts to become leaky. And what if it already was leaky before the injury? Do you think they're going to have more of an issue after? So listen to the gut. Listen to all 4 quadrants or all 9 regions, and listen to see if there's bowel sounds in every one. It takes a little bit of time, maybe 2 minutes, but you need to listen. Make sure there's activity coming, bowel sounds.
So after an injury, would you recommend doing like vagal nerve stimulation, like mouth or gurgling?
That's great. He asked, do you recommend after a brain injury that we do vagal stimulation, gargling, singing, so forth? Definitely, especially if they have a compromise to that. Yes, another question.
How would you change this to check newborns or babies?
You can still listen. It's hard for the other ones. You just do what you can. You can't get a communication in a 6-month-old necessarily, but you might just check to see. You might check your primitive reflexes, and that gives you a big idea. So check your rooting and your palmar and your Babinski, and check your ATNR and those other primitives, TNR reflex and the Moro reflex. Check all those, and that will give you a lot more depth into whether or not the frontal lobe is inhibiting. All those primitive reflexes should be gone by age 1, maybe 14 months. So that's a whole nother. If you guys are interested, we can do some other classes later. I just can't. I didn't even put that on here. I wanted to, but I didn't. But I asked a whole bunch of people yesterday, what do you want to learn about concussion today? And they gave me some good ideas. So I've tried to include some of that in there. And what do you do with toddler injuries? We'll be talking about in just a minute. All right, so we're flying through the anatomy. Now, if you haven't noticed, I'm giving you the high yield areas right now. Brainstem is one of them. Someone who has very cold hands or has chronic nail trouble or purple hands or splotchy hands, or if you have capillary refill that's very slow in the toes and feet, that's reflective of distal circulation in the brain. It's really hard for the brain to have what it needs if it doesn't have appropriate blood flow. So let's move to the cerebellum. How well do you know the cerebellum? Write it down. Do you know the 3 lobes of the cerebellum? Just shake your head yes if you know it. Good. 3 lobes of the cerebellum. Yell them out. Okay, we got left and right, so we got 2 hemispheres. We got anterior and posterior lobe and flocculonodular lobe. That's a cool one. I don't really care what you call it. We can call it the FN lobe or just the thing tucked up under there. But there's the lobes. So you just sort of need to have a feel. It's like someone once said that, well, that doesn't have anything to do with it. It's just you feel more comfortable when you know your way around an area. So you need to know your way around the brain a little bit. And eventually when you start to know the names of the brain regions and know their functions and then know how to examine it, and then you can take a good history. We'll talk about the whole process in just a minute. But you need to know that the anterior lobe and the posterior lobe and the flocculonodular lobe all have different functions, but they all work together, of course. So, this has to do with balance. And so what cranial nerve might this area talk to often in regards to balance? Vestibular nerve. Good. And so this posterior lobe has to do, does it look bigger than the anterior lobe?
Yes.
Do you do more complex things with your hands or more complex things with your feet? Maybe Cristiano Ronaldo has a bigger anterior lobe. I don't know. Dr. McGinn.
What about tinnitus? Is that related to anything with the floccular nodular lobe?
Usually not, but as far as I know, but I could be wrong. Even though those two nerves, the vestibulocochlear nerve, share so the question is, does ringing in the ears have to do with the floccular nodular lobe? I don't think so, but I could be wrong. That's the other thing. I could be wrong on some of this. This is just my interpretation from where I'm at. I'm going to probably know more next year, and hopefully you guys all do too. So the anterior lobe has to do with control and coordination of the lower extremity and pretty much global muscle tone. Posterior lobe is bigger, and it does much more complex timing. Piano players have a big posterior lobe. You have to write and use your distal extremity in order to do that. All right, does that help? So if you think about the function of that area, just, you got to make sure you check some of these big ones. Cerebellum is a big one. Now, let me go back. Look at the size of the cerebellum in comparison to the rest of the brain, and it's just sort of how it looks. It looks like the fissures are smaller. Does it look different to you guys? And if you look at a cross section, it's just beautiful. It's like these branches and leaves go in all different directions. From what I've learned, the cerebellum has maybe 40 times more neurons than the whole rest of the brain. How many neurons are there in the brain? Like 100 billion? And we'll just say all together. So there's a certain large percentage, even more, that's located in the cerebellum. Now, that means that if you have dysfunction in the cerebellum and you are able to get it to change, then you can actually get a rapid change, and it's very plastic. I had a patient that called one day, called my office back, it was like in May, and then he asked my staff if he could come get treated. He wanted to get a video motion x-ray at my office of his neck. He was calling from Wales. And I said, well, how'd you find me? I just found you on the internet. I was like, well, okay, you're going to come out to Bountiful? He goes, oh yeah, are you near any place called Bountiful? And I said, yes, that's where I practice. He goes, well, I have an old missionary companion I'm going to visit. I said, oh, you're going to visit him and see me while you're there? He goes, no, I'm going to come see you and visit him while I'm seeing you. So I came. He had been rear-ended by his wife when they bought a new car. And he'd been suffering. They were just driving home with this new car, and his wife forgot to stop and got rear-ended. And it'd been almost 2 years, and he couldn't get in to even get an MRI. He was on the books to get an MRI a few months and years out, but he couldn't get his... and no physical therapist or no doctors would really do anything with him until they had the MRI. And I examined him, and I had him put his arms out in front, and I had him close his eyes. And he almost fell over. I grabbed him. He said, oh, thank you for grabbing me. I said, well, have your other doctors done that test before on you? He goes, oh yeah. I said, well, what did they do? He goes, they just let me fall. They said, there's no way I could be that dizzy. And so he would have policemen sometimes approach him in the grocery store because he was just sort of walking in sort of this wide-based, sort of drunk-looking stance. And he didn't consume any alcohol. But it turns out within 2 or 3 days, we were able to get his cerebellum turned on. I should have put that testimonial. I have his testimonial with his great accent somewhere in my computer. But I don't have it handy. Anyway, so cerebellum responds very quickly. So if you want to have a quick win on any patient, you got to check the cerebellum, examine it, and then you'll be able to make a change. So we'll talk more about examining in just a minute. Okay, so this would be a good chart that you could try to learn, and you just want to look at any one of these 14 brain regions and look at it and say, what is it? What's the function? Where's the vision area? Oh, it's right in here. What controls balance? Right here. What controls our complex thinking and executive function? Right here. And you can just go through what controls our memory and our emotions. right here. So you just sort of need to go through and just make sure you can identify these areas. That's sort of like step one. Like you don't want to try to diagnose a concussion and someone says, okay, doctor, you diagnosed this concussion. Maybe just, Dr. Croft likes to use these analogies about people being on the stand, but I'll use the same thing. So what area of the brain was concussed? Oh, well, he was feeling really dizzy, and I'm pretty sure he had a concussion. And so what area would be related if someone had dizziness when they had a concussion? Yeah, see? You guys can get it. What area, if someone was just like really dazed and they had sort of blurred vision? Occipital lobe, maybe. What if they just stopped being able to speak very well, or they just couldn't? Parietal, maybe. Wernicke's area near the upper temporal lobe. So you just have to sort of link these in. You guys know these symptoms already. You've seen them all, but you just need to be able to, when you make your diagnosis, I want you to be able to diagnose the brain region the best you can. And sometimes I diagnose the top 3 because almost always there's more than one. So diagnose the brain region and diagnose the side as best you can. And then you're a little bit closer. All right, so I wanted to share this with you because I just kept putting things at the introduction, and I knew that I didn't want to leave it to the slide 200, so I'm just going to go over some of the things that I tell patients right at the beginning. And I had a patient come in, a 20-year-old kid, young man who came in who was wrestling with his dad and got his head accidentally, he slipped and slammed his head on the concrete or something. And he had a pretty good bell ringer. And so his mom sent him over. And so I gave him, a handful of different things that I wanted him to remember. And then he left. And then he got home and couldn't remember any of it. And she called me. She was ticked. She goes, I send people to you. How can you think you can let these concussed people go home without having something written? So I hurry up and typed up all this. And I just used it. It's not in any specific order. Based on different brain regions and different functions, you can adapt as you need. But I give people, it's called we'll call it treatment considerations, because there's things to consider. One of them is you want to make sure that people are hydrated. Sometimes they just forget to drink when they've been injured, and you need to make sure they're hydrated. There's research that shows modified, lower intensity or less consumption of calories takes a load off of the brain, because as the gut needs blood flow to digest that big meal you just ate, it pulls blood away from the brain. And so we'll talk more about it on the pathophysiology, but there's a metabolic mismatch. Within the first 6 hours after a brain injury, there's an increased demand and a decreased blood flow. So it's like wrapping one of those special floss things we had yesterday around our neck, and not just sitting there, but making you go run a marathon at that point. So it's called the metabolic mismatch. We have increased demand and decreased blood supply. So decreasing calories really helps. It also really helps to get rid of all sugars and grains for at least 7 days, because 7 days is sort of the magic window where a lot of people are better in 7 days, but you want to make sure that, you don't know. Did any of you guys ever read one of those choose your own adventure books when you were young? And you get to the end of the waterfall, and do you grab a hold of the branch, or do you jump onto the rock, and whatever happens. You don't always know what's going to happen. We get to choose our own adventure, and I'd always rather choose the adventure that pretends that if I don't do this, the patient is going to have a lot more severe outcome, or a much poorer outcome. So I say, look, do as much as you possibly can on this sheet. A lot of this we should be doing already. If we're not doing it, then we're actually at more risk to have a brain injury from a not too traumatic of an event. So take your vitamin D, take your magnesium. We all should be taking EPA and DHA. And I also like to have people take coconut oil, give some medium chain triglycerides for the brain. These antioxidants are huge. Actually, what and I usually don't recommend people start taking a ton of antioxidants and anti-inflammatories, herbal or otherwise, until at least 7 days, so that the brain does have a chance to do some inflammatory response to this injury, but then the goal is eventually to resolve it. Now, if you remember from your neuroanatomy and neuroscience courses, we have certain type of immune cells inside our brain that are different from the peripheral system. And in our peripheral system, we have an infection that comes in, and we mount a T cell response, and then eventually a B cell response, and then we have these Treg cells that dampen this inflammation and resolve it. But in our brain, we don't. We have these glial cells that just get fired up, and they start to just chew up tissue. And there's no way to really slow them down. And so sometimes you can just get concussed, and then your glial cells are still active, and then you just reconcuss again, and you're already just primed to have another injury. That's one of the bad things about second impact. BDNF is brain-derived neurotropic factor. It's a growth factor for brains. It's really the only way to boost it and stimulate it, besides taking some of those supplements, is to exercise. So, what do we usually tell the concussion patient to do right after they get injured? Well, that's not what the medical approach is, and that's not what most of us do. Rest. Now, avoid all stimulants. Avoid everything. Don't text anybody. Don't watch any TV. There's a point where we're creating couch potatoes out of people. They need connection and hope. And we're saying you can't go to school, you can't study, you're going to get behind. I actually think a light exercise is very beneficial. It's just what drives an increased symptom. We just got to pay attention to that. Maybe they got to go walk 10 or 15 minutes. It's better to have them walk in nature than to walk on a treadmill anyway. But sometimes you need to sleep, increase sleep demand when you're having a concussion. But some of the people who have concussions have trouble sleeping. We'll talk about the symptoms in just a minute. So, get plenty of sleep. Avoid excitotoxins. It's only important to avoid excitotoxins after you've been concussed, right? That should go on my myths question we'll be going over in a minute. So the ceramides are found in nitrites and alcohol, processed meats. All these things increase insulin resistance. That means we don't have as good of a fuel delivery to our cells. So you want to avoid those. Basically you avoid the things that really flare up your symptoms. So some people just can't go on an airplane because it's just too much pressure. If you get on the cell phone for a few minutes and you get a headache or you feel nauseated because you're scrolling up and down, maybe that's a sense that your eye movement patterns aren't accurate, so you might want to avoid that. Some people need to be sensory deprived for a little bit. Some people don't.
Try those sensory deprivation tanks.
I know there's some saltwater baths that they put people in, and I've heard they're fun. I don't know I haven't seen the research on them, but you have to, every concussion is different. So I've seen hundreds of them now, but everyone's different, and yours is different from someone else's. And then you do want to limit your stress hormones. So maybe you back off on school and work for a few days. The research shows that most everybody goes back to work within about a month after. At the long end, they go back to work within a month. Does that mean everyone's healed from a concussion? Just because they went back to work doesn't mean anything. Maybe they're running out of money. You can do capsule. There's lots of different forms of magnesium. The type that I found has been the most researched to cross the blood-brain barrier and do the best is a type of magnesium called magnesium threonate. I didn't put that on here, so write that down. It's a good one. So we're still on the things that I wanted to get out at the beginning. We're almost done with the introduction to this talk. So when can you return to play, or when can you return to work? So there's a few principles you need to go by. How many of you guys are confident that you can determine someone's ready and you know you're not going to give them brain damage if they go back to work or play? How many of you are pretty confident that you can do that? I do it, but I still don't know. Sometimes you just don't know. You get someone who's 2 months out from a concussion, they had a month of no symptoms, they've done all these things, they've practiced, they've had light contact, they've gone full intense, and then they could just like tip over on the ski slope and jar themselves, and now they're back. So I always try to, when I'm doing a concussion protocol with people, I require the parents, if it's high school athletes, to sign an affidavit and communicate with me about each one of these steps, because they need to have exercise with no contact, maybe 30 minutes or an hour, and then no symptoms for the next 24 hours. So just because you felt fine while you did your exercise doesn't mean you're fine. If you have symptoms, don't go back. I mean, you can do the light cycling or swimming, but don't have them go back if they still have active symptoms. Now, think about how much mental effort it takes us to see patients and to work every day. It can be pretty tiring. And I would usually recommend, as if people are going back to work, that they might go back in the first maybe half day, in the mornings only, because if they push it, it's what happens is you run out of fuel and you exceed your capacity. When you exceed your capacity, that's when things go bad. That's when you start getting symptoms. And you get what's called epileptiform, not a seizure, but it's like a seizure for that brain region. So if you have increased symptoms from going back to some kind of activity that you were avoiding for a while, then you'll notice, I need to back off. And you got to do something. Don't be just totally non-moving. And you'll find out the movement is some of the best thing to activate your brainstem region so that you can suppress pain.
So could you increase that each day?
Every day, as long as you have no symptoms. So the question is, should you increase this each day? Yeah, say they need to have a 2-hour soccer practice, and they need to be up to full time. Maybe they start 30 to 60 minutes on the first day, and if 24 hours later, no symptoms, then they go to full time before they do light contact. So they have to be up to their time that they want to exercise before they go to contact. So it might take 2 or 3 days sometimes to get through each one of these steps. And the parents have to email me or sign an affidavit that says that the patient didn't have increased symptoms. Otherwise, if they do, I mean, obviously I'd like to see them more often if we need to. But, I have lots of patients that come from far away, and it's not always that easy to do it. Okay, so this is still on the when can I return to play topic. If you have multiple concussions, and in one of the outcome assessments I'm going to show you in just a minute, it asks for that. So it's sometimes hard to remember all the things you need to remember, let alone all the brain regions and all the functions, and to examine every one of those. But you might forget to ask them something. So that's why forms really, really come in handy. Don't try to think you can just wing it and go off of your amazing memory, because maybe at 9 in the morning you remember everything, and at 3 in the afternoon when you see that patient you forget a few things. So if people are asking me, should I go back to football? Should I go back to wrestling? I always try to encourage people to either take up swimming or ping pong. We have very few concussions in swimming. We have had a couple, but very few. And ping pong, I don't know of any. So those are really good exercises for the breathing, for the coordination. And some people refuse to do it because they say they can't float. But you can use, wing floaties and things like that if you really need to. So I actually have a few questions that I'll ask people who are just really, you try to be motivational and positive and supportive, but provide them with the things they need. And one of the things, I just ask them, would you rather play in 1 or 2 more games at the end of the season, or be able to read to your children someday? Because, I don't know if you like that, but that's important bonding time with your kids. And how will your life be impacted if a second or a third impact causes you permanent damage? I mean, you guys know we're losing neurons every day. Every time, raise your hand if anyone has ever had a migraine. I think I've had maybe 2 in my life. I very rarely have had them. But every time you have a migraine, every time your patient has a migraine, they lose brain cells. A migraine is just one step away from a seizure. Every time a patient has a seizure, they're losing brain cells. We're already losing brain cells just by getting one day older. So a lot of us are more functional in our late 30s, 40s, and 50s in terms of our business careers because we've trimmed out some of the neurons that are superfluous, and now we are very focused on what we need to do. But from a neuropsychologist, I think McRory, I don't agree with everything he teaches and writes about, but the cornerstone of concussion management is physical and cognitive rest until symptoms resolve. But we'll just say, just alter your activity. It doesn't mean you're totally resting bed rest for that time. I think you need to be moving because if you lose and atrophy your muscles and lose that feedback to your cerebellum and lose those feedback loops, your pain will be higher. We'll talk about those symptoms in a second. So here's a chart that I borrowed from Dr. Karazian in Apex just to show you the difference between a healthy mitochondria and an unhealthy mitochondria. Now we know that mitochondria are really important for creating ATP, energy. You have healthy mitochondria, you get lots of it. And you have good endurance because you supply, you create a demand and then you can supply and meet that demand. When you have poor circulation or trauma or inflammation or lack of activity or blood sugar dysregulation or toxins, you don't manage inflammation well, you don't get steady fuel, steady oxygen and glucose, and you don't activate the brain, and you do not have healthy mitochondria. Your endurance goes down. So look over here at the membrane potential when you're healthy. It's down at negative 70 millivolts, and it needs to hit this minus 40 millivolt to fire all or none principle from neuron theory. Look at what happens to the threshold when you are unhealthy and you don't have ability to maintain the sodium-potassium regulation, keep the magnesium plug in the NMDA receptor. Your resting membrane gets higher. And that's actually a good thing for a neuron that's under stress because neurons that don't have activation eventually die. Would you agree? Yeah, they eventually die. So resting membrane potential that's closer to threshold means it doesn't take as much stimulation to fire them into excitatory or inhibitory action potential. So when your membrane's so close to threshold, there's, you guys treat much neuropathy? See lots of neuropathy patients and lots of brain injured neuropathy patients. When your thresholds are set high, you have pain from a normally non-painful stimulus. This is something called hyperalgesia, right? And if you have pain when you have no stimulus, it's allodynia. It's just like the air blows on your skin and it's like, that hurts. I remember working in the University of Utah physical med and rehab department back in, before I went to chiropractic school. And I remember this quadriplegic who had been he'd actually gotten shot robbing somebody's house. And so it hit upper spine and he was paralyzed from the neck down. And we would take him, to the shower and stuff, and we would put sheets on his feet, and he would just go, that hurts, that hurts, that hurts. He just couldn't tolerate very, very innocuous stimulations. And part of it was because his brainstem wasn't suppressing, but also because his thresholds were so high, it didn't take much to fire off the pain receptors. And he didn't have much movement to dampen the rest of the stimulation. All right, now we're done with the introduction. All right. So let's take a 20-minute break, and then we'll talk about the definition of TBI, concussion, and we'll go over all the outcome assessment forms you guys will need. Archives of Physical Medicine and Rehab defines concussion as an alteration in brain function or other evidence of brain pathology caused by an external force. Pretty simple. What does it mean to have alteration in brain function? That's good to know. What's considered alteration of brain function? Loss of consciousness is one. Loss of memory is another. Neurologic deficits. Any alteration in mental state. It's pretty broad. You'll find that these definitions, it's really difficult to I'm going to hold you guys to a higher standard than the medical literature holds people to. Here's another definition of concussion. He starts to cry. So there's about 2,000 people in the NFL and maybe 60 to 100,000 little kids playing football. So they've started getting these brain injuries early. See, he didn't have his foot on the ground. His one foot was already off, and so he got the guy that fell back, he got more of the load. So there's lots of ways the brain can move, and you can injure your brain in a lot of different ways. I was putting this talk together, and I thought, man, there's so many different ways. We can have mechanical injury, so like the brain can shear and move around, but you can also have, and if you look at the glial activity, we talked about the immune system a little bit ago. The glial activity in concussion starts and it grows as you go to a post-concussion syndrome. So you can injure the brain also by being struck by something, or your head striking something, or just moving the brain quickly without striking anything. That can traumatize the brain. You can also have something that penetrates the brain. And I did give you guys an article that was really pretty cool, showed some cool force vector diagrams on blast injuries. You guys ever treat any veterans or people who've been overseas and been deployed? It's this concussion is the signature. These blast injuries are like the signature injury of the war right now. So a lot of these IEDs go off, and they get a blast, and instead of gravity that goes about 32 feet per second, you can multiply that by when you have a 10G force in a whiplash, but we're talking 32,000 feet per second, and there's just astronomical amounts of force that move the fluids in your brain, and then there's this aftershock that sucks it back the other direction. The forces are so confusing. I actually went and tried to sign up for a fluid mechanic course, fluid soft tissue physics course, because I thought, this will help me with my brain. I lasted an hour. It was just way over my head. There's a lot of complexities in the physics. But there's lots of ways to injure your brain. I also thought that there could be something called an emotional concussion. You guys have heard of PTSD, so post-traumatic stress. You can see something traumatic, and that can cause a reaction of the glial cells in your brain. You can be traumatized that way, and I also think you can have, there's such thing as a chemical concussion. So you can have some kind of toxic chemical that causes some kind of brain inflammation as well. So I found this study that recommends that we stop using the term concussion. And the reason why is what you'll see in a moment. It's just confusing everybody. People think concussions are different than brain injuries, and it basically, according to this author, Sharp and Jenkins, they feel like it's just not, it has no pathologic meaning, and it's just confusing everybody, including the providers. So we're going to try to help you guys not be confused. All right, so 2012 consensus statement says concussion and mild TBI should be viewed as separate, distinct identities. The American Academy of Neurology in 2013 said, don't separate concussion from mild TBI. But there's overlap in this use of the term concussion and MTBI. So this is from the Mayo Clinic in another different study. It talks about two different types of potential classification systems. And if you look This one on the left shows severe up at the top, moderate and mild. Same thing, moderate to severe, a definite concussion or definite brain injury, probable brain injury, and symptomatic possible. So if we look at the symptoms, this is the one that would like separate the two. So mild, moderate, and severe brain injuries are here, and the headache, dizziness, sleep disturbance, cognitive impairments, fatigue, irritability, anxiety, and depression are the symptoms. And let's look at concussion. Headache, dizziness, sleep disturbance, cognitive impairments, fatigue, irritability, anxiety, and depression. It's the exact same symptoms. So how do you quantify that? It's difficult. So if you were to classify, just so you know, because we talked about mild traumatic brain injury is mild only because it's not life-threatening. But the symptoms are not necessarily mild. Excuse me. The symptoms are not mild. They're very life-threatening and life-altering. But if you have death, then you had at least a moderate or severe TBI. Just in case there's any doubt. Loss of consciousness, 30 minutes or more, moderate to severe. If you have post-traumatic antegrade amnesia, meaning you're forgetting stuff that happens after the injury, then you have moderate to severe. You lose a whole day after that concussion. You had a moderate to severe injury, potentially life-threatening. Moderate and severe can both end fatally. And then Glasgow Coma Scale, we'll look at in a moment, less than 13. And then as long as it's not attributable to intoxication. And then any of the other following vascular injuries, contusion, penetrating TBI, subarachnoid hemorrhage, or brainstem injury. So if you have brainstem injury, I just chatted with someone in the break who has some brainstem symptoms of injury, and it's potentially moderate to severe. So now what if none of criteria A apply? That's moderate to severe. If none of these things are true, then we'll just call it a mild TBI. So that means you have a moment of loss of consciousness, or maybe just dazed. If you're dazed, that counts as altered consciousness. And if you have a depressed basal or a linear skull fracture with the dura intact, then you can still have a mild. So you could actually fracture your skull, and they've actually had some research that shows that sometimes fractures absorb enough force so that it's actually a better outcome for your brain. So the bony fracture, which, I've treated a couple patients with bone fractures as children, bony fractures. They show the outcomes are a little better with the brain injuries if you fractured your skull than if you didn't. Sometimes it's a little counterintuitive. So if criteria A and B don't apply, then you could call it a possible TBI or a symptomatic TBI if you have one or more of the following: blurred vision, confusion, daze, dizziness, focal neurologic symptoms, headache, or nausea. Almost every concussion has a headache, so we know we're at least building from there. It's just whether or not you have some of the other symptoms. So I took a course on Coursera from the University of California, San Francisco on medical neurology, Intro to Clinical Neurology, I think was the name. And they say emphatically that concussion is likely different than TBI. I disagree, and the literature disagrees. I think if you have a concussion, you've injured your brain in a mild fashion at least. And like I said, remember, this is really important. Just because it's mild traumatic brain injury just talks about the life-threatening event nature of it. It's not enough severity to kill you, but the symptoms can be severe, debilitating. We talked to one of our colleagues here. I treated this girl, a college student, who crashed her bike riding down at BYU. She doesn't know how it happened. She just woke up and got her bike out of the road and doesn't know what happened, how she crashed or anything. Was not wearing a helmet. And she couldn't talk, hardly could think. She lives up in Morgan but was down in Provo, and I'm in Bountiful. She eventually found her way to see me, and she could barely tolerate just being in a room even this dark. We were able to get her so she could tolerate some of the testing. She couldn't tolerate even an exam. It was just too stimulating for her. So we got her totally recovered. Her dream was to go on a mission, and she finally we had her doing return to exercise, return to work, focus, back to school, all that. And then she gets into the MTC. First or second week, piece of paper drops off the desk, and her and her companion both reach for it at the same time, bumps ahead, and then she's dizzy and nauseated for vomiting for 2 more weeks. She was able to get to the mission, but ended up having to come back. She was vomiting 6 times a day. So we were able to get that down, and she did her, she's actually had a pretty good, done pretty well, but she's seeing one of my other colleagues down in Spanish Fork, I think. All right, so when do you order a CT? This is pretty important, but most of the concussions I ever treat, we're already past this point. So I'm not trying to train you guys to be emergency room physicians, but just in case this is your own child, then you make this call. So if Glasgow coma is less than 13, if you suspect a skull fracture, go ahead and send them for the CT. We're not going to adjust that away. If they have a seizure, go for it. Send them for the CT. You got to find out why. If they have focal neurologic deficit that's progressing, and I don't know what they mean by that. To me, I find lots of deficits that are functional, but I don't know what they mean by focal. So don't ask me. More than one episode. One episode of vomiting, my son's in the audience, and he had a buddy, went skiing a couple weeks ago, fell over, hit his head, felt nauseated, went to the bathroom, threw up, came back, kept skiing. And his buddies are arguing that he didn't have a concussion, and my son was right, he did. If anyone's on blood thinners, you need to be getting that CT because things can go bad really fast. This is sort of humorous. If someone's over 65, they probably need to get checked because their vessels are just not as dynamic. If someone is currently have a bleeding disorder, a history of blood issues, then they need to get a CT. And also, if there's a dangerous mechanism of injury, now that means so many different things. It says if you fall from a height of more than 1 meter or 5 stairs. Now, you guys know that if you just fall from 4 stairs, you cannot get hurt, and it's not dangerous. So, you guys have to use your own discretion on that. Pedestrian or cyclist being struck by a motor vehicle, that's a dangerous mechanism of injury. But most falls, I tell the story every so often. We treated this young 82-year-old, and she came in for neuropathy treatment. And she had some pretty severe balance issues. Wasn't really dizzy, but just had some bad neuropathy. And we did our testing and treated her first day, and she proceeded to go out down the steps and fell down. I don't know, we have an elevator in our building. I don't know why she didn't just go use the elevator, but she decided to go out and use the cement stairs, and she fell head first. Smacked her head, split it open. So she went to the hospital, got her CT. A month later, we continued her neuropathy treatment, and was very successful. I like this definition. Concussion is used to describe both a pathophysiologic condition and a constellation of symptoms arising from MTBI. So all that discussion about what TBI is and isn't, basically it's symptoms and pathophysiology. So basically, I don't know if any of you guys can look inside someone's brain and tell what kind of pathophysiology is going on, but if you have enough symptoms, then you have it. So I just want to encourage you guys to call it more often and say it confidently. And I would prefer that you didn't use concussion unless you just need to lighten it a little bit. But most of the time, tell people it's a mild traumatic brain injury. You have a mild traumatic brain injury, you need to treat it as such. The problem that we have is we don't want to be too confrontive, and you just need to call it. And then if people recover in 7 days, great. If they recover in a month, great. But you need to have them being aware of what their condition is. You have a much higher likelihood of treating them and resolving their condition and helping them take it seriously if you diagnose it. It's a left cerebellar concussion and right frontal lobe concussion. You have the signs in your exam right today. Let's get this brain healing faster. There's another thing called acquired brain injury. I learned about this at the Brain Injury Alliance. But, this is a type of brain injury that's doesn't occur from trauma, but it's acquired, like you drown or have a stroke or get an infection, lead poisoning, choking, carbon monoxide poisoning. I had this one lady, after I spoke at the Brain Injury Alliance, I had this tiny little room. I wasn't the keynote speaker, but I was one of the side speakers. And they packed in like 90 people in this room that was only supposed to hold like 40. And everyone just swarmed me afterwards. They're trying to find, because these people who are involved in this Brain Injury Alliance have all had brain injuries, and they want options. They want treatment. And this junior high school teacher she had a little office to the side of the gymnasium, and it had a furnace or something in it. That she got carbon monoxide poisoning and had severe brain injury from it, and she would have died had not someone found her and pulled her out. But these look very similar. You just, wherever that oxygen and hypoxia is, you get damage. Here's a quick overview of Glasgow Coma Scale. Raise your hand if you can know what the lowest possible score is on the Glasgow Coma Scale. Lowest possible. 0 is a good guess. We'll go 3. The lowest you can go is if you don't open your eyes, no verbal response, you get 1. Another 1. If you have no motor response, you get 1. So even if you're dead, you can get 3 on the Glasgow Coma Scale. I've never really used that on a patient, but it's part of the literature, so I wanted to share it with you guys. So how do we stratify these? Let's just go through this real quick. We've got these 5 different categories. Structural imaging, see over there, mild traumatic brain injury / concussion, right up here. So just look here. You can still lose consciousness and have a mild TBI. If you're over 30 minutes, you're moderate. If you're over 24 hours, you're severe. Alteration of consciousness, less than 24, over 24. Post-traumatic amnesia, none maybe, or 1 day to 7, and then Glasgow coma. You could have a 15 totally perfect response on every one of those 3 categories, and you could still have an MTBI.
How common is the amnesia with?
I don't know. I don't know the answer to that. It's probably more common than you think, but the problem is in concussion, a lot of times people are alone. There's no witnesses to the accident, or the collision or what happened. People can sort of be dazed or sort of out of it. Maybe they were out for a few seconds. In whiplash, I hear that a lot. People who have concussion in whiplash, they're like, well, I hit, and then there was someone like, I didn't lose consciousness, but I don't know how that person got to me so fast. And most of the times they like to deny it because they think that's the only thing. If you just don't have a loss of consciousness, you're fine. Perfect. That's what I just told you. So if we don't have witnesses, it's hard to reliably get this information. So let's talk about some of the outcome assessments that are available that I use and that I recommend you use, at least some of these. Start with the acute concussion evaluation. That I recommend you use on every acute case, or at least have your staff go through that with them, and then you have to make a decision and sign it at the bottom. You'll see that in just a second. Rivermead, to sort of track outcome assessment in terms of improvements, you can use a Rivermead. Nordoff concussion symptom impact form, I've found that and I like it. If people have sleep symptoms, they either have trouble sleeping, or they're fatigued, or they can't fall asleep or can't stay asleep, I use this just to quantify. because these forms help you think of questions you probably wouldn't think of. There's also the graded symptom checklist and the sport concussion assessment tool, the SCAT, which I've never used. I will not tell you that I'm the guy that is the sideline doctor. I just haven't done that. I'm in my office and they come to me and usually they've already gone to the emergency room if they're going to. And so I'm not the expert on this sport concussion assessment, but those tools are out there. You should, if you're going to be involved in sideline assessments, you need to be very familiar with those. So from the literature in the Journal of Neurology, this is from that course, UCSF, the post-concussion symptom scale is 64 to 89% sensitive, 91 to 100% specific. So you can get pretty specific about whether or not it's there, but the standard assessment of concussion, I've just seen these different names for those, so I tried to find those. If you just use orientation, immediate memory, and recall, then up to 94% sensitive and 91% specific. All right, so here's half of the acute concussion evaluation. Now remember, this form, I found it for you. You can search for it. I found it on the internet. You can probably find it too. But if you look, it has the patient or a guardian or a loved one help fill this out. When the injury happened, what the date is, and describe the injury. And it helps in how bad or poorly they do this is also a frontal lobe test. There's not a lot of great frontal lobe tests other than gait and coordination, finger tapping and so forth. So history tells you if their frontal lobe is intact. So if they keep wandering off, like I've done a couple times in this, but I'm trying to give you stories that help support what I'm teaching. If they can't do a concise explanation of the injury, either they forgot, or a lot of times they just don't know what happened. So you do get the best information you can, because if someone hits a certain part of their head, and then you think about the coup, contra coup effect, bouncing from one end to the other, then you want to sort of be specifically careful to check both of those brain areas. And then you go through what type of where the impact happened. Was there a bruise or a goose egg on the head? Any evidence of skull fracture? I don't know how a patient would know that, but maybe the raccoon eyes, they might know. Where the impact happened, and then how it happened, and then do they have amnesia? See, these forms really help you. They help you ask the questions, and as you start to get familiar with them, you need to use them and start to feel, and you'll start to have this feel like, yes, I know, and if they're all no's, no, mild, zeros on all this. So now we go to the physical, cognitive, sleep, and emotional symptoms that the patient has. And it's either yes, 1, 0, no. If they don't have it, and a lot of times they'll circle in between. Now, if they circle in between, it's a yes. So you just add up the physicals. Total, 0 to 10. Cognitive, out of 4. Emotional, out of 4. And then the sleep, out of 4. So, also if exertion, physically exerting or cognitive exertion makes them worse, that tells you something about their endurance. If the patient has endurance issues, what likely is a problem for them? What is a problem if they can't endure? They do something and then they can't maintain it. What's the problem? Blood flow. Blood flow. They create a demand, they can't sustain it with blood flow. So you got to think about that. Now, section C goes over risk factors. This is something you should already do, but maybe you don't. Do they already have? I mean, I've had people up in the 10s. I'm like, you need to stop doing whatever it is that keeps causing these things, because you may not be able to read to your kids someday. How long the symptoms lasted for the longest episode? Did less force at successive times cause new injury? So I have this basketball player, super nice kid, 16-year-old. He's massive. He's got this big sort of afro, he has some, I don't know exactly what nationality he is, but he's maybe islander of some sort. But he had several concussions playing basketball, and then he just had a girlfriend at school just go to give him a hug, and her jaw bumped his head a little bit, and he started getting concussion symptoms. And it's like these concussions are happening closer and closer and closer with less and less force. So his glial activity is not really resolving. His inflammation is still just primed. So you can just, maybe then you could just plop into a chair just wrong, or have someone jostle you in a crowd. Boom, you all of a sudden you got a concussion. Had another little kid, 12-year-old, had smacked his head on the ice skating, and was doing better after about a week. I hadn't seen him for this one, but then he was going somewhere with his mother in the Suburban, and she was just backing out, and he was just reaching forward to turn the radio, and she just turned to look back as she was backing up, and just bumped his head with her hand. Boom, started getting his concussion symptoms again. So there's very innocuous insults that can cause these symptoms. So here's some red flags. You should know this. Worsening headaches. So headaches that are worsening. Anytime you have a neurologic symptom that's progressively getting worse, that should be telling you something. Seizures, not good. Drowsy and can't be awakened. Repeated vomiting, slurred speech, can't recognize people, confused or irritable. Weakness and numbness in the arms and legs, and neck pain, change in state, behavioral change. All these. And then these are ICD-9s, but I have, at the end of my slides, I have pretty much all the concussion diagnoses that I use that are ICD-10. You'll want to look at those, because I categorized them by brainstem region, by symptom, and by just concussion diagnoses. So hopefully that helps you guys. And then a follow-up. What do you plan to do? Send them out, refer to neuropsych, send them to the ER, figure it out. You got to make a decision. You're going to call the concussion, you got to create a plan. All right, recognize this form? Rivermead. 16 different symptoms. Just 0 to 4 is how you grade these. Is this helping for me to go through this? Because I know you guys can probably look at it, but I just want to sort of guide you a little bit. I know it's sort of boring, but the thing that is hard, I talked about baselines before, that sometimes people already have headaches, and then they get a concussion. Their headaches are either more frequent, more intense, or more lasting longer. So you might look at this. If they don't have any of those symptoms, then they circle 0. If they have the same symptom as they used to have before the trauma, they would circle 1. And so if they have all these symptoms and they're 16, they're about the same as they were before. They probably haven't had a change in brain injury state. Does that make sense? So, and then from there it's mild, moderate, severe, 2, 3, or 4. And you want to do this with an acute concussion. I would do it after a week of treatment, and then after another couple weeks of treatment, and then after that monthly. Dr. Carr.
Would you tend to use one like this as compared to the previous one if the person was by themselves and they're unreliable?
Yes.
Because a lot of times the concussion patient will come in and it's like they don't remember, they can't tell, they're not able to cognate, and it's supposed to okay.
So Dr. Carr's asking if I would tend to use the Rivermead more if someone was alone and can't really relate the history of how the injury happened. And I mean, it's ideal if you can know the history, but to me it's actually not mandatory. You just want to take where they're at and help them function better and heal quicker. So it's a luxury if you have that. I have a lot of unreliable historians that come in with brain injuries. So yes, if they're forgetful, if they have poor concentration, they have sensitivity to light. Sequoia.
What are some of the on the 1, 2, the other things? What are some of the common other symptoms?
Sometimes someone might say, I just forget words. So word finding is pretty common. Maybe they used to be fine, but now their hands and feet are really cold. or maybe they just stumble a lot, maybe they drop things. So it's whatever they bring up in their history. You might say, all right, just let's grade that. Did you have any of that before this accident? No. So just quantify it for me. And then that, you want to use those same things, because what you'll do is you take those 16 symptoms, and you total the whole total, and then you divide it by, multiply it by 4, and then divide it, and you get your percentage. Does that make sense? So if they choose 1 on everything, 16, and there's 16 times 4 is, I want to say 64. Yeah, 64. So you just divide that by 64, whatever their score is, and that's their baseline where you're at today. So it helps. And I liked hearing Dr. Harrison's talk earlier today about what's significant. 5 points on a neck disability index is significant statistically, but 10 points is more significant to what the patient notices. All right. So if you want to do a little mini mental status exam on yourself or a loved one, you can pull up this MMSE. It's also sometimes known as Folstein's. So do you guys ever feel like you wish you knew how to quantify cognitive function a little bit better? I think in a lot of the training I did, it was heavily vestibular focused and heavily sensory based, and it was very poorly, these cognitive functions were very poorly addressed. So when I found this, I was like, yes, I have something that I can use. And so you just ask them, what's the year? Season, date, day of the week, month. If they get it, they get a point for each of those, and you just write it down. You can have your staff do it, or you can do it yourself, but it takes about 10 minutes, maybe 8. Then you state 3 or 4 objects, have them remember them. They have to state them back to you. And can you remember velvet, church, daisy? Red piano. Maybe you make it harder. In this one, it's only 3 objects. And then you say, all right, say it back to me. Velvet, daisy. All right, what was there? One more. Was it some kind of a building? Church. Oh, yeah. So you get them to say it back to you first, and then in 5 minutes, it'll remind you to ask them again. Count backwards by 7s. This is called serial 7s. 100, 93, and then so forth. Anyone, you want to stand up here and do that? 193, 86. All right, and then spell world backwards, and then there it is. Tell me the name of those 3 things a couple minutes later. Just hold up this. What's this? Oh, it's a laser pointer. What's this? A watch. And you just go through. They get the points. Repeat the phrase, no ifs, ands, or buts. We're just trying to get just the speech areas. Are they able to differentiate these sayings? And then you have someone you have this written out. Take the paper in your right hand, fold it in half, and put it on the floor. So you show someone that, and you have them read it and be able to do it. If they can, and then you have another one that says, close your eyes. Do what this says. Then you show them the words, close your eyes, and if they close their eyes, that means they can read and follow that command. This is actually a really common one we use in neurodegeneration. What you guys will realize, if you start to get good at TBI, eventually you have to get good at another thing. What is it? Neurodegeneration. Because how are you going to, part of the whole reason why we want to address and treat these brain injuries early is because we want it to not become neurodegeneration. You have 1 concussion, you're already at higher risk for neurodegeneration. Copy this picture. Little pentagons overlap slightly. And you just watch how they do it. If they can do it, they get a point. So we see, if you're 26 or over, you're pretty much, mental status is pretty much intact. If you're under that, it needs work. See, there's Folstein's attributes right there. So there's another symptom checklist that I found, recommended by the National Athletic Trainers Association. Frequently administering. It's like the river mead, but it's a graded symptom. So you have to grade the symptom instead of just saying I have it. Now you use a number from 0 to 6, sort of like a Likert scale, but I think Likert's 0 to 7. And they just, what's my baseline? Now, every one of your athletes that you treat should have one of these before the season starts for whatever contact sport they're in. And then when they get injured, how does it compare? 24 hours after, 3 days after, 4 days after, 5 days after, 1 week after, and every week after until the symptoms resolve. It's repetitive you can choose if you like this one better or the Rivermead. This one's a little bit more comprehensive in terms of symptoms, and I like it because it gives you a severity. You can see those severities going down as the patient's getting better. All right, so there's 2 more forms I want to introduce to you. Some of you may have heard about them, but would it help you if there was like 5 or 6 questions for each brain region just to help you just boost you on the path of sort of learning these? Most people are shaking their heads yes. So the brain function assessment form was provided, and I got permission from Apex Energetics to put it in the Dropbox folder, so you can get a digital copy. And you go through these 10 or 11 regions. Every one of these brain regions have 3 to 5 different questions on them, and they grade it from 0 to 3. So what I really recommend you guys do, when we send out the link, print them out for you and your loved ones, and just see if you have any signs showing up anywhere, because it's really important. Those quiz questions I asked you at the beginning about, are you noticing that you're not at your peak right now compared to how you used to be and how fast you're changing? You want to know where you're at so you can actually do something. If you guys are here, you actually inherently believe in the beauty and the miracle of neuroplasticity and the ability of the brain to change. So let's find out where your brain is weak, and let's address that area and do some things that will help. There's actually a key that I included that gives you exercises for each one of these brain regions. Is that good? I totally forgot we even had it. So, what's the difference between the direct pathway of the basal ganglia and the indirect pathway? Anyone know? Dr. Huntsman, come on. All right, so he said it right. The direct has to do with initiating movement. The indirect has to do with suppressing movement. So if someone has a problem initiating movement, like a neurodegenerative case or someone who freezes, then that's more of a direct pathway problem. But what about the person who has, like, the kids that have tics, blinking and Tourette's and, jerks and all sorts of unique, what problem do they have? The indirect pathway is not dampening movement like it should. It gets confusing sometimes. You're like, all right, the direct pathway and then inhibition of the inhibition, it can get complicated. We're not going to go too complex yet today. Now, the Brain Health and Nutrition Assessment Form is a good one because it helps you look at the metabolic component and the neurotransmitter component. So we have serotonin and dopamine, and what are some of the other neurotransmitters? GABA, acetylcholine, all these, glutamate, they all have a lot to do with, oh, they're right there. You guys are really good. You read them really well. So these are the neurotransmitters. So there are specific symptom patterns that are related to deficiencies of these neurotransmitters. And if you support those neurotransmitters with cofactors, you can make a big difference in helping these people function better. But what if someone has low essential fatty acid? They have really dry skin all the time and they're cracking knuckles. They don't have enough fatty acids. And do you think their brain's going to be happy? No. What about the brain-gut axis? We talked about it. What if someone has a problem with insulin resistance? What's the result of long-standing insulin resistance on the brain? Yeah, eventually you get Alzheimer's, and it just drives inflammation. Because when your blood sugar goes up, your insulin needs to go up to bring it out of the bloodstream. If the insulin's going up, that's actually toxic to the brain and the brainstem. So you don't want to have chronic insulin elevations, otherwise you cause brain degeneration at a higher rate. So fill out the form. Brain Health Nutrition Form, Assessment Form, BHNAF, and the BFAF. Fill those out tonight. There it is. All right, have we learned anything so far? Let's quiz you guys. See how good you have learned. You need to have a head hit in order to sustain a concussion. Good. So there's lots of ways to do it. You can shear it, you can twist it, and if you look at the side view of the brain, you see that so much of it is forward from where it's attached. It's not like a basketball sitting on a fence post. It's not that balanced, and so it doesn't matter, even if you have linear acceleration, deceleration, you're actually shearing the brainstem. And so you need to be able to analyze and examine the brainstem in order to find out these deficits. All right, here's another one. True or false? Can you have a concussion if you didn't lose consciousness? Have you ever had that happen? But doctor, I didn't lose consciousness. Or, but I did have my helmet on. You can have a concussion with a helmet on. NFL proves that. Most concussions don't have a loss of consciousness. So from the research, most don't have a loss of consciousness. How's this one? Is this true? Would you rather have a concussion or a mild traumatic brain injury?
Either one.
Neither. Because concussion is by definition a mild traumatic brain injury. That's my definition. So just so you know, I just recommend you guys don't talk about concussion so much. Just diagnose your patients and tell them it's a traumatic brain injury. It's mild because it's not life-threatening, but if it was life-threatening, you would also send them out to the hospital and they'd get their CT and they'd be able to find out where that subdural hemorrhage is, and then they treat that, and then you still need to treat them afterwards. All right. A true concussion is a rare event that usually only happens to people that don't wear proper head protection. Is that true? And so there actually are less concussions in rugby because people aren't using their heads as a spear. And there still are plenty of concussions in rugby. What is the most, and I've seen different, let's just see how current you guys are on the literature. What's the most common girls' sport to cause the most concussions? Soccer, and I see another one that says lacrosse is way up there. And lacrosse is actually, I have a couple high school lacrosse player girls, and they don't wear helmets in Utah. So to me, it's ridiculous. I mean, I know you have different rules, and you're not supposed to hit people in the head with a stick, but it can happen accidentally. So if I was on the lacrosse board, I'd be having the girls wear helmets as well. Question in the back.
A lot of their injuries come from falling and smashing their heads on the ground. They shoot with their stick, or when they're in a pack, when they fall, they roll out. When they hit the ground, it's like their head.
Yeah, so the doctor's saying a lot of them, they're falling and they fall and hit their head on the ground as they're having these concussions. I mean, they're also holding a stick, so that sort of takes away some of their protective force. I mean, maybe they're having less elbow fractures and shoulder dislocations, but maybe they're having increased concussions.
Smack each other in the head.
They're not supposed to smack each other in the head. That's against the rules.
Laying in their head, banging each other.
It can happen. No, yeah, those balls are moving fast. There's some pretty good girl athletes. So I've done this lecture in the past, and I titled it 3.5 Potentially Fatal Myths About TBI that everyone, that's you guys, everyone who treats TBI should know. But then I changed it to be the fatal myths that everyone with a brain should know. All right, so let's cover a little bit of the statistics just so I can make sure I'm thorough. 3 to 10 million people are affected in the United States annually from concussions. 3 to 10 million. It's probably less. It's probably even more than that. I mean, these are based on emergency room statistics, And so of those who raised their hand earlier that they knew they had a concussion, how many of those actually went to the emergency room to become part of this statistic? Like less than 10%. So there could be 100 million concussions in the US. Who knows? 475,000 children. Most of the traumatic brain injury is mild traumatic brain injury. And according to this study, 85% resolve within 3 months. So this helps you predict. You can tell people this. The amount of severity on the Rivermead, their amount of severity on their graded symptom checklist, their amount of severity on their acute concussion evaluation, those all, you can say, all right, this is a mild, a moderate, or a severe mild traumatic brain injury if you want to. That's confusing. But give people the idea, yeah, most people do resolve in 3 months or 6, but 15% experience long-term disability. That's 1.5 million. That's a lot of people getting chronic disability as a result of concussion. So how does it shake out? What are the different ways in terms of percentage? We've got 40% on the falls, 19% are other, 14% vehicle accidents, and then some accidental blunt trauma to the head. And that one is 10.7% assaults. I found this article. Unlucky toddler takes first steps before plunging 9 feet onto the tiled floor. So I looked at this other picture, if you want to look this article up. You look at the stairwell that this kid fell through. At the time, he was just starting to learn to walk. He right after his first steps. And what happened was the spacing of the rails was good on most of the stairs, except for at the top, it was an extra inch. And so as he was losing his balance, there was a towel hanging on this banister. He sort of reached to stabilize himself and fell through 9 feet to the tile floor, fractured his orbit. When I was young, they had a lot of those little, I don't know what they're called, those little roller things that they have the kids stand up in, and they have wheels and they sort of motor around when they can't walk. I mean, a lot of parents are totally against those because if you have stairs in your house, somehow those manage to go down the stairs. I've had several patients that did that. I had one little baby who I saw, this is probably my very first concussion case I ever saw. She was about 1.5 years old. I saw her last week. She's like 12 or 13 now. And her mom brought her in because she had fallen. She was sitting on the bed, and then she just went to get up or lost her balance, and then fell between the bed and the wall, and sort of smacked her head on the wall, and sort of, sandwiched herself down beneath. And then she had been walking for a few months. She stopped being able to walk. She would try to walk and just fall. And so I didn't know hardly anything about concussion at the time, but I knew how to check her cerebellum, and her cerebellum was injured. And so we did some adjusting and some complex movements, and she responded so well. So amazing. She stopped speaking even after that for a few weeks. But then she came back. So traumatic brain injury causes a lot of deaths in kids and adolescents. The biggest ranges for risk are 0 to 4 age and the age 15 to 19. So between 0 and 19 is, you got to get your kids that old, because the risks go down after that. 62,000 children sustain brain injuries regarding hospitalization. 564,000 children are seen in hospital emergency departments for TBI, and they're released. And what do they usually release them with? What kind of instructions? Rest, anti-inflammatories, and sometimes follow up with your primary care provider. A lot of primary care providers don't really know how to treat concussion, I'm finding. A lot of deaths, a lot of hospitalizations. So let's talk about the mechanics of concussion. And then we'll get into the pathophysiology. I think we'll have time to cover almost everything. So let's look at the different types of brain injuries that can happen. So you can have linear impacts. And in linear impacts, if you think about a cross-section of the brain, you've got a surrounding fluid, and you've got central ventricles also have fluid. So in these linear impacts, there's movement of fluids. So just remember that. And you got this 3 to 5 pound mass of jello that's just jiggling around. And it's got fluid in and out. And if you've ever slid a bowl of liquid across a table, the liquid has inertia and it wants to keep moving, and it sort of cycles after that. So that's how you get the Q contra Q effect. Rotation with impact, whiplash without head impact. We'll look at a couple of those in just a second. And then sideways without impact, and rotation without impact. So the sideways T-bone type collisions, I mean, you could die in a 5 mile an hour collision, and some of these people just don't take it serious. I mean, almost all of them, pretty much 95% of the whiplash patients I see, when I started screening them for brain injury, guess what? They all have concussion. They have brain injury. So if you're not screening them, and if you look at it from a legal perspective, Brian Larson and Jeff Metler and Randall Meek and some of the other attorneys out there will agree with us that you need to appropriately diagnose these cases. And don't forget to remember to do that. Remember to do it. Check, screen with these forms. If they're negative and they don't have anything coming up, no physical symptoms, no emotional symptoms, no cognitive symptoms, no sleep symptoms, great. They just have some neck pain, good for them. Treat their neck and heal them up. But rotation causes that brainstem to stretch and to shear. And I'll show you some pictures of that in a minute. But when there's a collision in whiplash, you have multiple collisions that happen. So the first collision is the car hits another car. That's the first one. And then the second one is some part of the occupant hits a car, like the seat or the steering wheel or the seat belt. Any of those can cause trauma. And then now the brain's moving because now the speed of the body has started to shoot forward if you're getting rear-ended, and the brain wants to stay still, and so it starts to shift backwards. And then that's when you can get the fluid shock wave right after that. So it shifts back, shifts forward, and you're hitting this jello against the sharp edges of the skull. It's not like an egg where it's all smooth inside. You guys remember that, right? You guys all did anatomy dissections? So watch this head. Head moves last. How many concussions do you see there? Or how many collisions do you see there? Super slow, mild.
How much do they get paid for that? Yeah.
So we take a little calvarium there, the inferior half, and then you look at all these different openings. So we'll look at it from the side in a second, but this is like a 3-level, upper level, middle level, lower level. Tentorium's right here. Tent across it. So there's all these holes. Cranial nerves go in there, cribriform plate. This can shear and decrease this ability to smell. Hypoglossal canal, jugular foramen. There's blood vessels. There's all sorts of crazy stuff going on here. So here's a side view. See the difference? So if you get hit perfectly from behind, your cerebellum can still hit the clivus there, or maybe this is the clivus, I forget. Anyway, it's going to hit skull, and then you got the pituitary fossa there, and there's a lot of shearing that happens at the hypophysis, and of course the frontal lobe can hit the beginning right there. Another different view, just showing the cranial nerves. I really encourage you guys to get good with cranial nerves and get good with your cranial nerve exam because this is something that has powerful, like it's really, you can change things really fast with people. If someone has a reflex, what's a really important reflex that you need to be able to do when you eat? Swallowing. So ask people, are you having any trouble? You guys do review of symptoms, review of systems. So as you go through these questions on your initial intake, make sure you ask people about, these would be on the neurologic symptoms. Do you have trouble swallowing? Do you have trouble, do you always feel like you have to clear your throat? Like there's just always something there. And then you can take your little tongue depressor and you push their tongue down, you look at their palate elevate, and you should have when you say ah, their palate should elevate both sides. You guys do that? It tells you so much. If one side goes ah, and the other side goes ah, there's a problem on that lower side. Now sometimes it's asymmetrical to start, and both of them will elevate. Is that as big of a problem? I don't think so. But look at the gag response, and then while you're there saying ah, just sort of slide your tongue depressor down the back of their tongue and just see how far it takes before you cause a gag response. And just pretend you're looking to see the palate or something and you're shining your light. When you look at, make sure you use a light, you can see it much better. And then you slide it down the opposite side and just make a note. Weak gag response or absent gag response on the left side. And then guess what you're going to do for an exercise to help them drive their brainstem? Swallow is one, but they've probably been swallowing. It's not good. Every time they brush their teeth, 2-3 times a day, just have them create that gag response 4 or 5 times. When that reflex is gone, people don't breathe as well. They have a lot more risk of having apnea at night. So I think, to me, that's like a huge one. If you guys just check that, it makes it much easier for you to tell what abnormal is when you know what normal is. So you got to start looking in people's who aren't injured, looking in their throats and looking at on your initial exams, do this 45-second cranial nerve exam. It doesn't take that long. Do your field of gaze, have them smell something, look in their throat, stick out their tongue, see if it deviates, check their sensation, check their jaw, have them swallow, shrug their shoulders. There, you got your exam. It's almost everything. I see a lot of people with gag response deficiency in traumatic brain injury. A lot of people. Dr. Walden, you see it? How many of you guys checked someone's gag response in the last week? Raise your hand. We got 2 or 3, 4 of us in the room. Check them. It's not, it's important. See that? Let's watch that again. We got it. When it flashes, that's when the collision happens. He hit back, he ramped up. 13 G's of force with a 6 mile an hour delta V closing velocity of 9.9 miles per hour. 10 mile an hour collision. Yes, it can cause a concussion. All right. So let's talk a little bit more about what happens when fluids move in the brain. It's just a speaker, just vibrating. So lots of fluid mechanics going on. When you have a concussion, that fluid, it's like a bullet. It can go pretty fast through and damage tissues. And remember, we also have lots of blood flow. We also have blood that's actually straining at the blood vessels. So we've got the lateral ventricles, third ventricle, Right here is where the aqueduct of Sylvius is, right there. And then the fourth ventricle, right at the central area between the pons and the cerebellum. So those fluids move, and that could be part of the reason why someone gets a concussion, because those fluids reverberate in the tissues, especially in blast injuries, I'm not going to talk about this for more than, there's a lot of complexities in the fluid mechanics, so we'll skip that. All right, so motor vehicle traffic injury, most of us treat auto injuries, and the rates are highest for death in the 20 to 24-year-olds. But you know, those people who die, they're not the ones we see. We see the ones who survive. Why do you think there's more concussion and more injury in whiplash and automobile collisions nowadays compared to before?
People are unaware of sex.
Lots of reasons. There could be distracted driving. There could be, you know, there's more, when you have the railroad collisions back in the 20s and 30s when they started researching this, you know, railroad cars aren't very elastic. They're not forgiving. And then we have those old sedans that are just made of steel and they're really heavy and they absorb a lot of force. But what happens now is our cars and our bumpers are designed to take more force. And so that means the deaths are going down, but injuries are going up. So people are surviving catastrophic collisions, but the injuries are more prevalent. Does that make sense? So what is the end result of repetitive brain injury? What happens? What are we trying to avoid? I mentioned it before. We don't want cells to die, and we don't want to have global cell death and buildup of proteins that cause neurodegeneration. So look on the left, someone with Alzheimer's disease here. And when you look at these scans, you basically look at the gyri and the sulci here, and you look at the ventricles. And the bigger the ventricles are, the worse it is for you, because that fluid's taking up more space. So severe TBI, this is a 14-year-old with severe TBI. 14-year-old. Looks a lot the same, don't you think? Maybe not quite as much degeneration near the deep temporal lobe, but these ventricles don't look good. Here's a healthy 14-year-old. Look at the surface. You don't see, it looks like it's full. And in these severely TBI and the Alzheimer's, you see these big furrows. And you're just losing neuron volume. There's a lot of people who are famous who've had neurodegeneration: Muhammad Ali, Michael J. Fox, Hugh Grant, Elvis Presley. Lots of people die early because of traumatic brain injury and chronic neurodegeneration. Here's an advanced CTE picture. Look at that. Look how big those ventricles are. Look at that central sulcus there. Look at the ventricles, normal brain. It's just beef jerky. So I've alluded to a lot of it, but let's just go through it in a systematic fashion. Here's how we evaluate TBI. We start with the history, just like you always do. Then I like it if you can sort of, if you take your history and you are like, I already sort of know where it is. I think I know where the lesion is, because I want you to identify. My challenge to you is when you take your next TBI case or your next whiplash case and you screen them for TBI, that you go ahead and just go out on a limb and say, I think it's a frontal lobe concussion and a secondary temporal lobe with some cerebellar. And then you have evidence that tells you why that is. So by the time you start your exam, you should already be thinking, I already sort of know where this is going to be. And you observe things like, what would be a sign before the patient even gets to your office that they might have a frontal lobe problem? Because we know frontal lobes are important for executive function. And Can't find your office. A lot of people. Forget the appointment, or come in half an hour late, or forget to bring their paperwork that you sent them. So with our concussion cases, we don't like to even schedule them until they filled out the form. Or we'll schedule them and say, this has to be here 24 hours before our appointment. Otherwise, we waste the time because it takes way longer. It might take you guys 20 minutes to fill out some of these forms. It'll take these guys an hour and a half. So how fast they fill out the form also tells you they may have a frontal lobe problem. So I want you guys to look at observe some of those tendencies and make a note. If it takes them another 20 minutes to explain the financial policy, they might be having a little frontal lobe difficulty. So functional neuro exam, you got to evaluate the brainstem. You also want to evaluate your cervical spine, because I've found so much that when there's brain injuries, guess what? There's upper cervical spine injuries. When there's upper cervical spine injuries, there's brain injuries. Why do you think the concussion symptoms, TBI symptoms, and whiplash symptoms are so similar? Because you're disrupting tissue. And then you need to take some time to assess and do some care planning. So we're trying to get more and more of these nutritional biomarkers, and I like to take a Home Depot laser infrared thermometer and just measure their temperature at their toes and their fingers, and then compare that to their forehead or the base of their sternum, and just look at the difference in temperature. It should go about down maybe 10 degrees, but I see people over and over in the 75 degree, meaning 75 at their feet, their core temperature is 95 or something. I don't know if it's stand up in court, but I like to show people, yes, you have an increased demand. You're trying to heal your brain, but you're not getting blood flow there. Nutritional biomarkers we like to look at. Homocysteine is important because if a pregnant mother is not adequately supplied with B vitamins, there's a higher chance of having birth defects and cord syndrome. So if we need it to develop and grow our cord in our brain, we need it to heal our brain. I'm glad I got to this. Cognitive status. So there's a website called cnsvs.com that is CNS Vital Signs is what it stands for. And there's a gentleman named Del Cook who I met last November at the IAFNR conference in Las Vegas. And he has a program where you can do a computerized neurocognitive assessment that's 30 minutes, and it goes through several different detailed brain status and brain function tests, reaction time, verbal ability, memory, learning, all sorts of different things. And if you just log on to there, and you can download the software for free, and then I think you may have to call them, maybe you don't have to, I forget, but you can have 5 free tests. So you can do one yourself, and then maybe you want to do one on your spouse or one of your kids who's had a concussion, just get a baseline. And it's actually harder than you think. You have to sit there for one of those tests for 5 minutes just waiting for something to happen. And I slipped a couple times because it was late at night and I got 2 errors. So, and then once you call Dale Cook, he'll give you and do a 30-minute webinar with him. He'll explain you a little bit more about how the system works. Then he'll give you 10 more free tests. So you can have up to 15 free tests on this system. And I charge $125 for the patients to do this cognitive status test. And there's been millions of tests that's been done. There's peer-reviewed studies and so forth on it. In addition, there's also several outcome assessments included on the software that aren't for cost. And once you do your 15, then you pay for $35 or $45, I think, for a test, and then you can charge the patient whatever you want to interpret. But I really recommend you do that at least, and you should do that for a baseline. But the outcome assessments on there, I think they have a depression index and a blast injury index, all sorts of different indexes that are free. ADD indexes for learning disorders in kids. And then you also need to make sure you're checking balance and ocular function. So how do you check ocular function if you don't have a $30,000 computerized vestibular nystagmography machine? Well, you can have the patient follow your finger from arm's length to about 4 inches from their nose and see if they can tolerate convergence. Most people with brain injuries can't. Most people with chronic migraines can't. So convergence is a big one. And then you want to check pursuits in the horizontal plane at 2 or 3 different speeds, slow, medium, and fast. Make sure you do it at least arm's length away from their head so that they don't converge. And you just watch the eyes. Do they smoothly follow the target, or do they chop? If they chop, they have a parietal lobe pursuit issue. And then you also want to check it, and it's also potentially a pontine issue, a Pons issue, because the Pons has what cranial nerve that deals with eyes? Cranial nerve 6. Abducens will move the left eye laterally, the right eye laterally. So the Pons has to do more with vertical or horizontal eye movements. So you can use your exam to diagnose these different brain regions. Do it vertically, that has more to do with the upper brainstem, and the horizontal tracking has to do more with the Pons region. Now, there's also something called saccades, where you're moving, looking quickly from one target to the other. I would hold my hands out like this, maybe this far, and have them look at one and the other as quick as they can, see how they can do that, or have them hold my hands here and have them start looking at my nose and look at the finger that moves. And then I move it over here, and then I move it again. And then you have someone do something that's looking, it's called anti-saccades, which is look at the finger that doesn't move. So you move this one, they should look over there. And the kids really have a hard time, kids with attention problems and adults with attention problems have a really hard time suppressing it. Okay, so here's how we deal with a case from a functional neurology perspective. And I encourage you guys to look at sort of how you deal with patients and just think about your process. Always do some observations. Especially look for gait. Gait is one of the key factors in looking at frontal lobe function, but we a lot of times don't even take time to watch the patient walk. It just takes a second. It's one of the important, if you're ever billing any insurance on 99203, you're supposed to note gait and posture. So make a note about it. Are they limping? Do they have a wide base gait? Do they have a circumduction gait? If you treat people with strokes, they will. And then you have them, walk forward, and you watch for arm swing. Should be symmetrical. If they have decreased arm swing on one side, just make a note of it. Then you have them multitask, and you say, I want you to tell me every other letter of the alphabet as you walk along. A, C, E, G, and watch what happens to the arm swing. Does it change? And it only takes less than 30 seconds to do both of those tests, and you just note if the frontal lobe's intact. If someone, A, C, it messes them up to dual task. So you don't want to do too much dual tasking, otherwise you exceed the capacity of the brain, the frontal lobe. So you do your thorough history, find out the mechanism of trauma, and then do your exam. And I think you should listen to the gut, make sure there's bowel sounds, listen to the heart. It'll get better as you start to hear more. I've never really diagnosed someone with an arrhythmia or a valve defect, but I still try to listen. Then I want you to make a diagnosis. This is what I talked about before. Just dare to make a diagnosis as specific as you can right in that moment, right when you're doing the exam. When you're done with the exam, I always record all my exams so that I force myself to tell the patient what just happened while I'm doing it, and then I just tell them what my impressions are. Frontal lobe concussion on the left with right cerebellar concussion, midline and intermediate. Excuse me, my nose is running. All right, and then how do you evaluate neuron fatigue? What you want to do to evaluate neuron fatigue is to find out if the system's stable. So, say you're checking someone's cerebellum. Their arms are out in front. You have them close their eyes, feet are close together. You guys want to try this real quick? Stand up. Feet close together, arms out in front, eyes closed. Thank you. And then bring your left pinky slowly to the tip of your nose. Some of you did right, but that's all right. And did you hit it or miss it? Then bring it out. And then slowly bring your right pinky to the tip of your nose. Slower, slow. Make him do it slow. It's harder to do it slow. Okay? And then bring it out. And then fourth finger on the left, bring it slowly to the tip of your nose. And what you look for is not just whether or not they hit. You can relax, open your eyes. Not just whether or not they hit the nose, but you look at sort of how the trajectory of that happens. So sometimes they'll get to here and they'll sort of stop and maybe their head will tremor just a little bit. Or maybe their balance sort of goes so what you know is we're looking for coordinated activity, and we're looking at the cerebellum on that test primarily, but sometimes the patient doesn't have an awareness through the parietal lobe of where their hand is in space, and so they sort of, jiggle as they come in. A lot of times, so the classic cerebellar tremor is an intention tremor, and it just does that at the very end. If it has an intention tremor, you got to make a note of it. Some of these findings are subtle. It's harder in babies. Had a question at the break on a baby, but you just got to do the best you can. And what I would recommend that you start doing is choose 3 or 4 cerebellar tests, like finger to nose, tandem gait with one foot in front of the other. I don't know if you can see where I'm standing. One foot right in front of the other with the eyes open and closed, and you just time it. They should be able to do it for at least 10 seconds. Most of the time, if they're over 6 years old, they should be able to do that for 10 seconds. And then you do, so we got a finger to nose, then I have you do a coordinated finger test where you just move your fingers real fast, open and close real fast, and then you have them put one arm out in front like this, put one hand down, and then have them close their eyes and come back up and touch that. Have them do that both sides. Just take 2 or 3 or 4 of those tests and check everybody's cerebellum this next week, and you'll start to see it. People have more problems with their cerebellum than you. If they need to be treated in your office because of chronic neck or back tightness, they almost always have a cerebellar problem, and it's usually a midline cerebellar problem. We didn't talk about the nuclei in the cerebellum, but there's a midline, intermediate, and lateral. Finger to nose is more lateral because it's out in the periphery. If they are more can't find where to move their angles of their wrist and elbow, then it's more likely the intermediate. Look at neuron fatigue. If you test a brain function several times and it gets better, great. But if you test it one time and then you test it again, then test it again, and it just gets worse and worse and worse, we're looking at neuron fatigue. So you don't want to drive those guys too hard, or else you will cause them to crash. You guys ever done that before? Where you've adjusted someone too much, or you did a little too much stimulation? That is a big one. Evaluate the neuron fatigue. If it gets better as you test it, then repeatedly, then that's a good sign. That means the patient can tolerate some neurologic rehab. If it gets worse, the more you test it, you might want to look at the metabolic factors first, like making sure they don't have insulin resistance, making sure they're breathing properly, making sure they can get oxygen. And then you just treat the findings and then retest it, show it's better. And it's not going to last forever. Just like you test someone's neck after they get adjusted and it's moving better, it's going to have a trailing effect. But I like to get immediate results with every patient, every visit, at least 2 or 3 brain regions that they have issues on. So let's finish up with some category, just so you guys can keep this in your mind. I try to make it simple and then we'll make it complex. There's several categories of symptoms you have to be aware of. We talked about them on the acute concussion evaluation form, but now we're going to talk about SPEC for the 4 categories of concussion symptoms. If you ignore sleep or ignore cognition and you only work on the pain that they're having, physical symptoms, you're not giving this person the adequate treatment that they need. So SPEC is pretty easy to remember. Sleep symptoms, physical symptoms, emotional or behavioral or mood symptoms, cognition. This is like foundation. You have to have this sort of in your toolkit so that you can remember this anytime that anyone wants to talk to you about a concussion outside of your office without your forms handy. Remember these 4 categories, because someone will say, yeah, I hit my head this and that, but I don't have any neck pain, I don't have any headaches. Do you think I had a concussion? You don't know. They just told you they didn't really have any physical symptoms. Sometimes people don't think dizziness is a physical symptom, or nausea. Did you have any nausea right after? So there's physical, that's what people tend to discuss most. And then you're like, well, are you having trouble sleeping? Oh yeah, I get to sleep and then I wake up every morning at 2. And that happens in a lot more people than just brain injured people. Neurodegeneration is a big one. Hypoglycemia and other issues are also very common to have sleep issues. Cognitive, of course, if you have memory issues, problems focusing, problem maintaining focus for more than a few minutes, then you have a cognitive sign. Emotional. No one really wants to admit it, but are you more irritable? Do you snap at people? Are you getting mad for what seems like a no reason? Those would be some emotional symptoms you want to pay attention to. Any one of these can lead you to symptoms and a diagnosis of concussion. See how I built that up? A little more simple and complex, and then we add the colorful version. Drowsiness, trouble falling asleep, sleeping too much, irritability, sadness. Some people just have this just overwhelming sadness. I really recommend you guys read some of the books that I put at the end of my slides. There's one called The Concussion Crisis, and there's also another one called The Ghost in My Brain by, forgot his name. I'm thinking of a different book. Anyway, The Ghost in My Brain. It's good. He talks in extreme detail about how he loses his energy and how he's an extremely smart computer scientist in artificial intelligence, and he just has this concussion that just plagues him for almost 8 years before he finally started to recover. So there's another way to look at this: cognitive, somatic, physical symptoms, sleep issues, and affect. These are just different symptoms that people can have. Amnesia and confusion, brain fog. Brain fog is so common in concussion and TBI. Tau neurodegeneration, this all leads to cortical issues, and then there's different things we need to look at. So that's why when you start to look at how much you need to evaluate with these cases, it's good to have more than one person. So what I did is I took a symptom and I labeled what kind of memory and some different brain regions that might be involved. You can look at this later, but balance and gait relates to frontal lobe and cerebellum. Extraocular reflexive control of gaze, pursuit, saccades, cerebellum and pons, midbrain, collicular maps. I just went through what type of brain issues could you have with each of these, and you can, look at it at your leisure. So if any of you have ever heard anything from a neurologist named V.S. Ramachandran, he talks about the ability of our brain. It's the only organ that can contemplate itself. We have it's impossible for us to have a central brain injury without having a peripheral manifestation. And I agree with myself when I say that it's impossible to have a peripheral injury without having a central brain response, and this is the literature that supports it. When you have a nerve injury in your spine or your periphery, you actually affect your brain in the somatotopic maps that it relates to. When you have injuries that cause increased pain, it actually causes you an increased somatic hypersensitivity because your brainstem usually isn't suppressing it like it should. I just want you guys to realize that there's so much that you can do just based on what you already know if you just take a step into this arena. Check the gag responses and don't worry so much about you, just do what is best for the patient. Maybe you don't need to fly all around the country just yet. There's ways to do online streaming, but the ability of the brain to change and heal is only matched by our imagination. If we can find those issues that people are having dysfunction with, we can make them better. And I see those miracles happen, and I won't even call them miracles because the brain responds to injury in predictable ways, and the brain responds to healing in predictable ways. We just have to find that and help people heal faster. That's all I have for you.